Welcome back to Life Unfiltered. Today's episode features guest Natalie Richheimer. Natalie is a board-certified genetic counselor at Jscreen with clinical experience in adult, pediatric, and reproductive genetic counseling. She holds a master's degree in human genetics and genetic counseling from the Keck Graduate Institute. Natalie is a native Torontonian who lives in Los Angeles with her husband and 2 boys. She has published research in the Journal of Genetic Counseling on the impact of orthodox Jewish clergy's role in prenatal genetic counseling. She's passionate about reproductive health and education and community engagement. Natalie has special interest in outreach with the goal of increasing awareness of and access to genetic counseling, and partners with local organizations and high schools to provide ongoing community education and support. To find out more about the work she does, visit jscreen.org or visit the link in the show notes. And now, a word about our sponsor, Do Not Skip. They make all of this happen. Let's talk about something we all deserve: investment in ourselves. Whether it's taking charge of your reproductive health, prioritizing your mental well-being, or showing your skin some serious love, this is about you and your longevity. That's why I'm so excited to be partnered with my go-to brand for my own skin, as you all know about my excessive talking about it on Instagram, Rescue MD. A skincare brand that doesn't just promise results, it's built to empower women at every age and every stage. From their science-backed formulas, their proprietary ingredients like Lapicol for skin under stress, to their focus on real, lasting skin health. Rescue Skin MD is here to remind you that your skin is an investment, not an afterthought. Because life is busy, but self-care, that's something that is always worth talking about. With Rescue Skin MD, you're choosing radiant, resilient, and healthy skin. Visit rescueskinmd.com and take the first step in investing in you. Use code LLG20 to save on your next order. Welcome in, Natalie.
Thank you for having me.
Thank you for saying yes during this crazy time.
Yeah.
Let's give some color. We are currently experiencing probably the worst LA fires I think they're saying that the Palisades fire is the most destructive fire that LA has ever experienced. So thank you for still doing this. We both thought that this conversation was important enough to continue. So I appreciate you being here.
Thank you. And I appreciate you having me. And let's, find a way through this dark time to help people in a little bit of a different way.
I love it. That's a good reframe. So tell us, who are you? Where'd you grow up? Tell us a little bit about yourself.
Tell a little bit about myself. So my name is Natalie Richheimer. I'm originally from Toronto, Canada. I grew up there. I spent most of my young years there. And then I joke, I met my husband, who was actually in NYU in grad school at the time. I met him on a Thanksgiving weekend, the stories of Hallmark movies.
Yes.
And really, we fell in love and decided to get married.
What was he in NYU for?
He was in NYU for mathematics and computer engineering. So fancy schmancy.
2 smarty pants. Get married.
We try. But, we met each other. And I always joke, if you marry an LA boy, they really can't survive outside of Los Angeles.
Did you try?
I mean, we brought him to Canada, I think, in April, and it snowed. And it was probably one of the most traumatic things for him. He was like, it's the spring and it still snows here. I'm like, it's Canada. It snows all year round. And I didn't need a hard sell to move to LA and not see snow again. I always tell my kids I did my time.
Yeah.
And we moved out here to Los Angeles. I took a little detour. I don't say detour. It was an amazing 7 years to teach STEM to high school students. Big passion of mine is encouraging women to go into STEM careers, feel confident.
So you must love that trend, women in STEM.
Oh, love it.
That was for you.
That was for me, Kelly Girardi, who's the female astronaut. I'm like, I love you.
Yes.
I'm a big woman in STEM person, and I had really felt when I got pregnant with my second child that my time had really come to an end as a teacher.
Yeah.
Not that I didn't love it. It just wasn't the final place that I was supposed to be. I always thought I would go into medicine and decided to pursue a career in genetic counseling. I interviewed for graduate school 9 months pregnant. I always say, I think I was the most memorable interviewer just from that off the bat. Had my baby, went to grad school with him, and then became a genetic counselor. And it's been a really amazing journey. And again, I love what I do. I'm now a genetic counselor.
Okay, I actually want to go over what is a genetic counselor and what that entails, but what is it like going to grad school with a new baby?
You know what? It was interesting. I did grad school during the pandemic.
Okay.
So we had like come together as a family, and my husband was really supportive. He was like, if this is what you want to do, I'm going to support you in this. We had thought like we were going to need a nanny and we were going to get grandparents to help out. And then the pandemic hit, and graduate school, which was supposed to be in person for that first year, actually went online. Which was crazy. And I got to be with my baby at home.
Yeah.
It was a really intense time. Having a newborn in grad school is a challenge, to say the least. But it was so perfect, and I was so happy, to have him, and to be in graduate school. And we always joke, I'm like, if Noah doesn't end up smart, that's my fault, because he was with me in all my graduate school classes, breastfeeding and listening to like high-level genomics lectures.
This is osmosis learning.
I know. I was like, this one's going to be a smart one. And it was a struggle, but it's like every single step of the way I did it. I'm happy I did it. I don't know if you feel like this way as a mom, but I feel like when you're a parent, your time is so much more concentrated in getting things done. Like, you don't mess around. So like if I have an hour to study, that's going to be a really, really fulfilled hour.
Yeah.
Instead of like, before I had kids, it would be like, oh, I'm going to have a snack. I'm going to scroll through Instagram.
I'm still doing the scrolling.
We're all scrolling.
I probably need to stop that. But no, you're right. I mean, your time is focused. Like you didn't have the luxury of like messing around.
No, and I think it added a different layer to what I did, having gone through pregnancies, having gone through my own journey, and really shaping who I was as a provider.
Yeah.
So I really appreciated what I was doing, and I like had other, grad school is different than undergrad. You have people who are coming into second careers, people who are older, younger. So I really enjoyed being with my classmates and really learning from them and their experiences.
I love that. So what does a genetic counselor do?
Such a good question. I feel like we're like the secret menu at Starbucks. Like some people have heard of us, some people haven't. Genetic counselors are healthcare providers, but they have a very different kind of training, I would say, than your typical medical provider, in the sense that our training is non-directive, meaning our training is very about empowering patients to make decisions themselves, not us telling them what to do.
Okay.
Huge part of what we do.
So a huge distinction between a counselor and a doctor, say.
Correct. Very different. We're trained in genetics. We have an advanced training in genetics, in clinical genetics, as well as research genetics. So that's a big part of what we do. We also have the counseling background. So psychosocial, making sure people who come to genetic counselors, especially in a clinical setting, are dealing with really heavy emotional things. And so it's really important for you to have the appropriate psychosocial training, making sure that you're giving them the empathy and the emotional support, which is a huge part of what we do. And we're really part of the bigger healthcare team. So we work with doctors and nurses and PAs and all the other specialties to make sure our patients are really getting good care. And referring. We do what we call risk assessments, so really helping people understand what are the chances of developing that condition, or if they have that condition, how does that impact their life, and how do they manage that condition? Who should I be going to? And so we're coordinating all that kind of care for them.
Is it a... Okay, so I have so many follow-up questions. As part of your training, I mean, some of it must be like psychological. I got it.
Correct.
Well, how, like, is it a huge percentage of it that's, because you have to deliver very hard news, often about people's life expectancy, or what their life is going to look like, or
their unborn child's life is going to look like.
Right.
Yeah, we have a lot of extensive psychosocial training. And like part of our boards, like you take medical boards, you take genetic counseling boards. I would say a huge chunk of passing that board is showing competency in psychosocial capability, because like you're saying, it's really tough. And people react to things in different ways.
Of course.
And you as a provider need to be able to handle that patient. You as a provider also act in different ways. So there's this concept of something called transference and countertransference. So sometimes we interact with people and we find them like we've never met them before, but they just like bother us.
Yes.
You know what I mean? And you're like, I don't know.
Oh, I
like,
know what you mean.
he just reminds me of my ex-husband. Like, oh, I can't, my skin crawl.
Right.
That happens with patients.
Of course.
It does.
Yeah.
And you as a provider need to be educated to understand, like, whoa, step back. I'm treating this patient differently because I'm having like some transference happening.
Right.
I'm having some
Right.
counter-transference happening, right? Like, how do I step back and deal with that and understanding bias? So that's a huge part of how we're trained, and it's not everything, but it's a very, very good portion of our graduate school training.
Now, so do you have did you focus on a specialty of what, like the counseling that you were going to focus on?
Absolutely. So genetic counseling is like medicine.
Right.
It is medicine.
Right.
There's a lot of different specialties. There's obstetrics, there's ophthalmology, there's cardiology, there's, cancer, reproductive, etc. I knew going in that I was very, very passionate about reproductive medicine because of my personal journey, because of being a parent, and I really wanted that. Some people will go through their training, they're not sure, they're exposed to different specialties, they enjoy that. I thought for sure that was what I had wanted to do. Cancer was something that I was a little bit afraid of before I went to graduate school. I actually really enjoyed cancer, really enjoyed my fellowship in cancer. It's just wasn't the area I chose to specialize in, but we do get exposure to all the different kind of specialties, and then people will pick one. Some people are generalists. Like you have generalists in like family medicine who do a little everything. You have that as well, and genetic counselors as well.
So reproductive, do you mean like fertility? Like what's included in reproductive?
Reproductive is people who are trying to get pregnant and people who are pregnant, and also people who are contributing to a pregnancy. So what I'm thinking of is like donors. So egg donors, sperm donors. Those are people who would come to us for assessments, people who are going through their own fertility journeys, people who are themselves pregnant, single, married, in a relationship. We deal with everyone who's thinking about having kids in some way, shape, or form.
Okay, that helps me because when I like when I put together all my questions, it was all around fertility, and then I went, wait, she's a genetic counselor. Like, maybe this is much broader, but I'm actually glad to see that I did my job. Okay, and so talk a little bit more about why, like the reproductive. You had a personal story around that.
Yeah. So it's interesting. I spent 7 years teaching, and I loved every second of it. But I always knew there would be a 2.0, and I'm somebody who, when I'm sure, I'm sure. Like, you tell me to make a very huge decision, I'll do it in 30 seconds.
I could tell by your knock on the door.
I have a confident knock. I'll do it. But if I don't know, like, I won't do it. So again, path in life for a woman who likes science and medicine, it's like you could be a doctor, you could be a nurse, or you could be a PA.
Right.
And I was like,
so true.
Those were like my three options. And I was like, I don't know, I definitely don't want to be a nurse.
Right.
PAs really weren't a thing in Canada at that point. So I was like, I don't want to do that. I guess I'm going to be a doctor, right? And I did all the undergraduate training. I did so many like different volunteer stuff. And like just my resume was padded to the high heavens. And like, I just was like unsure. Like, and I was like, if I'm going to go into that kind of debt, right, and take that time in my life to train, like I've got to be sure. And so teaching was something that worked for me, but I never felt like it was the right thing. And then, I had gotten married really young, and part of my journey, again, I had always thought I would be a doctor because that was the path for me. Part of my journey was finding out at the ripe age of 22 years old that I was going through infertility, and that myself and my husband, who both come from big families, never met someone who'd gone through infertility.
But how does one know at 22?
That's such a good question. So I'll tell you, at 22, we'd gotten married at 21.
Okay.
He was older, but I was 21.
Okay.
And we had wanted to have a family pretty soon after we got married. That was something we had wanted. We'd want to be young parents.
Yeah.
And I would say we had tried to get pregnant on our own. And after that 1 year mark, I wasn't getting pregnant. And that made me nervous. I'm a little more of an anxious bunny as a person.
Yeah.
And I really was dismissed by all my doctors. Like, it was like, oh, you're young. You'll just get pregnant. There can't be anything wrong. And I was like, okay. Had gone kind of like to a 2.0 with an OB.
Okay.
So we're just, doing some labs and everything kind of looked good. But I still wasn't getting pregnant. And at a certain point, I was like, I should probably seek someone who specializes in this. So I pushed to see a reproductive endocrinologist, so someone who specializes in fertility. And pretty quickly, we were thrown into a situation where it was like, so good news, we know what the problem is. Bad news is the only option for you to have children is going to be IVF. And that was like the scariest thing that could have happened to my 22, 23-year-old self of like, oh my God, IVF sounds really scary. I've never met anyone that's done IVF. Like, maybe like celebrities, I'd heard of that, but I was like, that sounds scary. I'm like 22 years old. I'm teaching. I don't have money, right? Like, how am I going to pay for treatment? At the time, like, I was terrified of needles. I now will give myself needles by myself. I'm totally not afraid.
Yeah, IVF really gets you over that needle feel.
I mean,
you
gotta get over it.
Yeah.
But I was just like, oh my God, how am I going to do that? And so there was like a lot of grief, and there was also a lot of anger. Right? Like, I did everything right. I got married young, right?
Yeah.
Only people who are in their 30s can have fertility issues.
But that's what I'm saying. Like, and this is actually one of my questions. So it's so interesting that this question actually ties into your life story. Because one of my questions is like, how do we know that we're not starting IVF too soon? Like, meaning everyone I know and their cousins doing IVF now. I mean, everybody.
Yeah.
It almost feels like, and correct me if I'm wrong, more people are doing IVF than they are even having natural babies. It seems like in my world, but that's maybe also because of my age. I don't know. But like, to me, and maybe this is what you talked about when you said medical gaslighting or like they dismissed you. I'm not a medical professional, but I would tell a 22-year-old, like, girl, you're 22. Like, you tried for a year. Like, that's not infertility.
100%. And that's really what happened.
Right.
But the reality was when we like scratched the surface, we really did find a real issue.
Right.
And we would have been spinning our wheels for another 5 years.
Right. Wasting time.
And again, I really have a lot of gratitude to the reproductive endocrinologist that we met with, who's like, you could try naturally and you could win the lottery, right? Sometimes it happens.
Right.
But like, if you want a baby, this is the path that will get you to having a baby.
Wow.
And so, I hear that. And I think that's where we have to really stop thinking in like terms of like, oh, well, everyone who's 20 should be able to get pregnant, right? Like, some people just can't.
Right.
And like for us, like, again, I'm like an all-in type of girl. My husband is like very not. He's a very chill guy. I was like, we're gonna do this now. I'm gonna get pregnant. It's gonna be great. Again, didn't work like that, but I went full force. But I would say, like, make sure you're getting the information you need to make your decision. Like, don't get pushed into IVF. Like, if there's a real reason for it, they should be able to show you that real reason.
Yeah.
And even if that real reason is like, I feel like this is what I want to do for my, mental health, that's a real reason.
So there's no sort of like, I guess if somebody's listening and they're like, what is enough time to know, like, maybe I should be trying something else? Is there a time period?
I would say, like, again, trying for a year and getting pregnant, that's typical. Over 35, they say like 6 months. Again, not a fertility doctor, so make sure you're talking to them. But if you've been trying for a year and having unprotected sex for a year and you didn't get pregnant, you should seek help with a professional. Now, an OB is an amazing person, gynecologist, amazing person, but they're not a fertility expert.
Got it.
So if I had a concern about my heart, I would go see a cardiologist.
Right.
I wouldn't just stick with my PCP.
Right.
Go see a fertility doctor. Like, I think people get really scared that if they go to the fertility doctor, they're going to get like, upselled like IVF and like all of a sudden they're just spending millions of dollars. No, like, just get a workup.
Right.
Get the information.
What do you mean by workup? Like a panel?
Like, make sure they're looking, again, if you have ovaries and a uterus, make sure they're looking at your ovaries and uterus. Make sure that you have
a uterus.
Make sure you have a uterus. Make sure your ovaries are working. There's no blockages.
Yeah.
Make sure that they're doing an extensive hormone panel for you and that your hormones are where they should be, right? Like, check all those boxes off and then make an educated evaluation, right? And a big part of that, I've been talking about this a lot lately with a lot of people, is AMH, right? Which is one marker of egg quality, right?
What does AMH stand for?
Anti-malarial hormone.
Okay.
So it's something that typically a fertility doctor or even an OB can order, and it can help you decide, like, egg freezing or IVF sooner than later. Again, it's part of a bigger picture.
Yeah.
But I would definitely just get the numbers. Like,
Okay.
be a strong advocate for yourself. And even if you're young, like if you want a baby, right, this is what you want. Don't let people gaslight you, because we know in medicine, like, your provider has 5 minutes with you
Yep.
before they pass you on to the next person. They're not seeing your full picture. The only person that goes home with your health is you. So make sure that you're getting information so that you can guide your health journey. And the only person that lives with the consequences of your health is you.
That's so true. So that path with you kind of really having a success story and having, getting what you wanted and having that successful IVF, that was like a no-brainer for you. Like, this is what I want to do for my work.
100%. It wasn't a successful path, ultimately,
Oh.
which is interesting. So we were like, and this is again part of setting expectations, I think is so important in the world of IVF. We were like, great, we found the issue, we have the solution, sign us up. We had a very successful retrieval.
Okay.
And we made lots of embryos. And then I was like, amazing. I'm going to have so many kids. I'm going to have all the kids I want from this one retrieval. I'm going to transfer. It's going to be great. I'm like a very, excited person. I even remember, this is so my early 20s, but I really wanted to go to, I think it was Bali. I wanted to go to Bali. We were going to Bali for winter break. I had saved up like all of our credit card debt. I had points. And I was like, I got to take it to Bali. It's like, if I'm going to be poor from IVF treatments, at least
poor and tan.
I would be poor and tan with fab pictures for Instagram. Okay. And I remember being like, oh, I'm going to transfer after Bali because I'm going to be pregnant. I don't want to be pregnant in Bali.
Right.
I'm not going to have a good time. Like, I was so sure it was going to work. I did a transfer, didn't work. I did another transfer, it didn't work. And understand, I say this to people, we didn't transfer one embryo, we transferred multiple embryos each time. And it the first time, okay, it doesn't work the first time. The second time it didn't work. And then when we had gotten to the third time, we really just weren't sure. Like, we weren't sure. The doctor wasn't sure. She was like, this should work. We did every extra blood test under the sun, tested me for everything that could be possibly, hiding, that could be causing me not to get pregnant. There was like an extra thing that we found out. It was like an extra medication that was very, very like obscure that they wanted me to take pregnant.
Interesting.
And I did it, and I did my third transfer, and I had my son. But
What was the time period of this?
from our retrieval to when I had him was probably not had him, but got pregnant with him,
Yeah.
probably like a year and a half.
Okay.
And really just hitting it as hard as we could. And I say that because they told us, like, you guys are in your 20s. This is just like a slam dunk. Like, you're going to get pregnant with your first baby so easily. And it didn't happen because, IVF is a numbers game.
Mm-hmm.
And even if you're young and in your 20s, there's no guarantee of success with IVF.
Right.
You've got better odds than if you were trying on your own.
Right.
But there's never a guarantee for success.
Right. Man, that makes complete sense. One would think. I always think in that way.
Yeah.
And I think it's so important that you're making this like distinction, because I think as a society we do have this thing where it's like young people, pregnancy.
100%.
But it's changing.
It is changing.
And why?
We've talked about this. There's so many different pieces to it. I'm like, again, a big believer in like people are exposed to a lot more than they used to be. This is not controversial. This is not me being a crazy hippie. This is just reality.
Totally.
There's a lot more chemical exposure. There's a lot more hormone exposure.
Hormone disruptors.
Endocrine disruptors that are in
Can
like
you give
our
some examples of like an endocrine disruptor, like a hormone disruptor?
like phthalates. That's a big thing in like shampoos and our body washes and our soaps. Like, and again, if you're not aware of this, you're just using that.
Of course.
That's continued exposure, right? Like, there was a big push for like hormone-free milk, right? A lot of other pieces where like we have exposure to things that our grandparents didn't have exposure to.
Yep.
And women are getting their periods a lot earlier, right? If you're starting your reproductive years earlier, that means in some cases you're going to end those reproductive years earlier, right? There's a lot of different kind of pieces to that. I also think like we're exposed to so much, radiation, and not hard level radiation, but like we didn't have phones. I mean, I didn't have a phone on my lap every day growing up in my pocket.
And the wireless headphones.
And like everything. And, like they've
The
done
Wi-Fi is the Wi-Fi boosters.
it's and again, like think about when our kids get into bed, like we had TVs when I was growing up,
Yeah.
right? You wanted to sit down, you wanted to watch your favorite show on TV, you sat down
Yeah.
in front of the TV. Our kids are like going to bed with their laptops on their laps and
Totally.
watching for hours.
Yeah.
Right? It's a very different world that we live in. And we are seeing like male fertility is very interesting. Like you're seeing decreased sperm count.
Yes.
Which is crazy.
Crazy.
And that's the world we're living in right now. Like I always say to people, like you can't change the world. Like this is the world you're living
Right.
in, but you can take steps to make sure your exposures are decreased, right? But there's a lot of peace. That's my opinion.
Are you seeing more in like your counseling? Are you seeing more of the issues stemming from male fertility versus female, or is it still even?
I see both. I really see both.
Okay.
I would say like people who end up with genetic counselors are a very specific subset of even the fertility group.
Got it.
I'm highly recommending if you're going through the IVF process, see a genetic counselor. They're not necessarily going to send them to you off the bat,
Okay.
but if you're spending that much money and that much time and that much effort, make sure it's a box you've checked off.
Okay.
Because it'll inform your testing a lot more.
Talk about that a little bit more.
So part of a genetics workup, and I always try and give this as an example, a short, like, wow, we are speeding through this genetic counseling session. Genetic counseling session is 45 minutes.
Okay.
45 minutes.
That's
short.
short.
That's short. Average time you meet with a doctor, what, 15, 20 minutes?
If even.
If even. So it's we're very detailed, very thorough people.
Okay.
A big part of that is, first of all, understanding what you want from us, right? Like we want to meet your needs, but also doing extensive family history collection and then stratifying that into a risk for you.
Okay.
So I talk with people about this. You may mention 1,000 things to your doctors and they may not put together the puzzle that we're putting together. Like, yeah, like now that you mention it, like my grandma did have breast cancer and then her sister had pancreatic cancer and then her, like my mom had melanoma. Now for a genetic counselor, we're like, we should talk about that.
Right.
For an average doctor, they're like, oh, people get skin cancer all the time and breast cancer is very common.
Right.
So we're analyzing your family history. We're putting that into context.
Are you guys more like strategists?
I don't even know. My son calls me a gene detective. That's what I am. I'm like a gene detective. We're really about the family history in a personalized puzzle. So I would say like we're very about personalized medicine.
Okay.
So if you're going to be telling me certain things, like, for example, if you told me that, like, your previous kid had autism and there was some cancer in your family, and by the way, like, a lot of people in my family have, like, very large heads. Like, a regular person would be just like, oh, okay. I would be like, we should talk about the following. It's just they are very common things for like other people that they don't have their genetics hats on and they're not thinking about that. So in a fertility process, right, if you told me, my dad had male infertility, I have male infertility, there's a very specific test I would run just to make sure that there's something.
How do we know who's the infertile one?
This is such a good question. I'm not about the blame game. I mean, they do testing, they do sperm count.
Yeah.
So they can and they can do physical like exams as well to make sure that like all the parts that you need to be, conceiving a pregnancy are there, right?
Because
like,
isn't it so important to know like which one of the parts?
Correct. And that's going to be part of a really good fertility evaluation. I'm going to say this because it's some old school medical gaslighting as well, but like it takes two people to have a baby, Adele.
Totally.
And a lot of the times, and I don't know why this is, the male partner or the sperm donor or whatever is not assessed till way late in the game.
Totally. Right.
Which
I feel like the woman they always test the woman first.
100%. And the testing is much more invasive for a woman than a man.
Of course.
So they have to do a small physical exam for a guy, check for any like varicocele, so like any blockages, take a look. Maybe they'll do like an ultrasound, and they'll do a semen analysis. They'll also do some hormone work. But like for a woman, there's a lot of different pieces they'll do.
Yeah.
Make sure whoever you're trying to have a baby with, make sure both partners are evaluated together and like in similar
Would you say
time
at the
frames.
same time? Yeah. Okay.
I would. To me, I wouldn't understand why you wouldn't.
It's like, why
do
waste
that.
time?
Why, exactly, especially if you're someone who's on a limited timeline because you're a little bit older in that process, right? If you're over 35, do both. Like,
Yeah.
let's get to the answer quicker. And then that helps, again, inform treatment, right?
Right.
If we're going to be dealing with someone who has an incredibly low sperm count or no sperm count, we're not talking about doing other things.
Right.
We're going to
What
go to
if
IVF.
there's no sperm count? Is it game over?
Depends. So again, not a fertility doctor.
Right.
Sometimes they can do a procedure where they actually go into the testicle with something called a microtesty and they remove the sperm that way.
Okay.
Because sometimes it's not that I'm not making sperm, it's just that the sperm doesn't have a way out.
Got it.
But again, you would want to go to a male reproductive urologist to
Okay.
have that conversation along with your fertility specialist. But
Okay.
but I'm all about, like, let's not waste time. Like,
Yeah.
let's get you to where, like, let's not make you suffer for longer.
No.
Yeah.
Okay. Preparing for an IVF journey.
Yes.
What should people know? Where does one begin? Anything like a checklist, like a must-have, must-do. Here's what you want to know.
From a genetic standpoint, meet with us. Make
Okay.
sure that you've gotten really good carrier screening. So carrier screening is something where we look at typically recessive or X-linked conditions. So those are conditions where we typically will have two copies of the gene, one from mom, one from dad. And because we have two copies, think about your kidneys, right? If you have two kidneys, typically if you have one, the other one is just kind of backup.
Right.
The other gene is backup. So
Got
there
it.
are people who are carriers, meaning they're born with one out of their two copies that don't work. They don't know about it because the other gene is doing all the work for them. The only problem becomes when you're trying to have a child. If the person you're trying to have a child with also has a non-working copy of that same gene, 25% chance with every pregnancy the baby gets no working copies has the disease. So you would want to know that before you started
Right.
any pregnancy, not just an IVF or fertility pregnancy.
Right.
Make sure that that panel is good. Make sure that you, and again, it bothers me to no end that, like, men are somehow, like, left out of the equation.
Always.
Always. Like, oh, we did for her, we don't need for him. Make sure you're doing that. If you have a fertility diagnosis, I also like to check chromosomes.
Yeah.
So, if there's an infertility concern, especially if there's been, like, pregnancy losses, you should take a look at the chromosomes. The chromosomes are just like big bookshelves of DNA. Make sure that all the information is there, like there's not huge chunks missing or extra, and that they're organized in a typical way, meaning they're not organized on different bookshelves, because that can really impact your fertility as well.
Okay.
Off the bat, you're doing those things. You should also check for, like, genetic types of anemias. So, very interesting. A lot of people don't realize they carry them. They're called hemoglobinopathies. And
Hemoglobinopathy.
hemoglobinopathies.
Just rolls off the tongue.
It rolls right off the tongue. Very standard test.
Okay.
Again, carrier screening should look at some of them, but I would also recommend just doing, like, a regular CBC, a blood count, just to check that, like, all the ingredients in your blood are there. If they'll flag if they're lower than they should be.
Okay.
Again, would impact how you'd plan out any pregnancy.
Yeah.
But especially in the world of IVF.
I mean, Daphna, our mutual friend who actually introduced us, is such a big believer in, like, so much of this infertility that we're seeing is just basic, like vitamin, malnutrition, and stuff, like, not a lot of it. But there are cases where, like, women are just, like you even said, like, there's a form of anemia or something that's not even like a lifelong genetic thing, but, like, people could it be that people are just not?
Can I say one other thing? Can we
Yeah.
be controversial together?
Say less.
Can we be controversial?
I love controversial.
I think everyone thinks that if you have sex one time, based on the TV shows we all watched in the 90s and 2000s, you should be getting pregnant. Like,
Right.
it just holding hands gets you pregnant on TV.
Like, you go under a
100%.
blanket and there's a steamy scene, and the next scene the woman's pregnant.
And then it's like, oh no, I'm a teenage pregnancy. What does one do?
Right.
That's not reality.
Right.
Like, human reproduction is actually very inefficient. And
Right.
so I've talked with so many women because I'm very open about my fertility journey.
Yeah.
About, like, I can't get pregnant. Do I need to do IVF? And I'm like, okay, girl, have you been timing your intimacy? Have you been timing your sex to make sure that it's at the best time? So many people don't do that.
Right.
So, like, make sure you're ovulating. Make
Yeah.
sure that you're timing when you're having sex with that ovulation window. Like, I'm just even, like, more basic. Like, the sexual education in this country is basically don't have sex so you don't get pregnant.
Right.
But we don't actually teach people who want to get pregnant how to get pregnant, which is bizarre. Think about what I'm saying to you.
No, the penny dropped while you were talking. I was like, wait, all we're ever taught is how to not get pregnant.
Not get pregnant and not get STDs. That's what sex education is.
But the world has changed so drastically. We're having harder times getting pregnant than we are not getting pregnant.
100%. And then where do you get that education from, right?
Right.
Like, who is telling you? Because according to sex ed in high school, if you have sex one time, you're going to get every STD under the sun.
And a baby.
And a baby. Because those
You'll
just
be
come.
both.
So it's so confusing for so many people when they end up in that boat and they're like, I know I just have to try more because I should just be getting pregnant.
Right.
Like, so many people from a basic level are losing basic fertility information. Like, we don't, we talk about in sixth or seventh grade health class getting your period, right? We never talk about like what's abnormal.
Right.
And I will say like social media has filled a really big gap. Like there's so
Yes.
many amazing providers. Shout out to all our amazing providers on there
Yep.
who are doing a lot of health. But like, I've spoken to so many people who come to my office. They actually have a genetic condition, like a blood disorder related to their very heavy periods.
Right.
But they were just like, I don't know. I just had a heavy period. And I thought, everyone has a heavy period because no one talks about that,
No
right?
one talks about it, especially PCOS. So,
That's like a whole landmine.
nobody wants to talk about it.
Nobody wants to talk about it.
There's no research.
I mean,
But so many women have PCOS.
It's so common. It's so under-researched. But like, again, like, we need to put more money into researching women's health because it's different than men's health. Like,
I mean, you hear all this stuff, and I hear it, and you must hear it too, right? Like when erectile dysfunction was a problem, it was like, well, they fixed it like that. There was so much research. There is a gap. There is a lack in the female research. What is that attributed to?
Think about erectile dysfunction. If you were not from this country, you would think it was like a horrible life-limiting disease.
Yeah.
Based on the ads we see on TV.
Totally.
Like, not to worry, we can help you. And I'm not taking away, it is a real problem. I'm not dismissing that. But I am saying there are women that are hemorrhaging because of their periods.
Yep.
And there are women who are dying in childbirth.
Yep.
And we don't have great ways to handle that.
Yeah.
Right? Like, I always say fertility has come a really long way because there's a lot of money in fertility, right? People will pay anything to have a baby.
The government is investing in fertility.
That's so cool. I didn't know that.
Yeah, well, I guess if you create the problem, it really helps if you solve it.
Well, we want a population to grow with.
Right.
So,
yeah, that's true.
But I say that like women's health so underfunded, right? True. And again, there's a major need. So, like going back to what we've been talking about, I think there's so many facets to why people are struggling to get pregnant, but really at a basic level, like we need to be better educating people because like women don't know anything about women's health. I shouldn't say don't.
I didn't. I still don't.
Many women don't know. And I will say like people who I'm talking to are really educated. They're PhDs and they had never heard of an ovulation kit. And that's just because who's going to tell them about that? Their high school sex ed class that they had? No.
Do you think it should be added in the high school sex ed class?
I'm a big believer in fertility education. I know that that's controversial for some people, but I think...
But why would it be controversial?
Because, like, if we tell people how to get pregnant, they're going to get pregnant, Adele.
But don't we want people to get pregnant? We have, like, a population problem.
I'm with you. Listen, I have a big belief in, like, it should be taught.
Yeah.
And people are like, oh, but high school. And I'm like, high school is the last place of formalized education in this country. Not everyone goes to college.
It's true.
Everyone goes to different college, different curriculums, different have that conversation. And even if it's not extensive, right? Give people the basic background knowledge so that they can then go like advocate for themselves with their gynecologist or OB. Like, oh shoot, I know that they mentioned in that health class that not getting your period for 3 months isn't normal. I should go check in on that, right? Or having periods that last 3 weeks aren't normal. I should go talk to someone about that.
Yeah.
Right? I think it's hugely important. I know that like, sexual intimacy for, having a baby should be timed around my ovulation. Like having that basic core thing so that when you're ready to have that discussion, if you're ready to have that discussion, you have a baseline. We have such a sex ed problem in this country. And, from a fundamental level, that needs to be taken care of as well.
We're so Puritan. Is there any sort of contradiction or discrepancy with like IVF and like religion?
Such a good question. Depends who you ask. That's a very Jewish answer to that question. I will say, like, I'm Jewish myself. you know, depending on what stripe of Judaism you are, I'm sure you'll find people who have issues with that.
Right.
By and large, if there's a reason for it, usually, you know, Jewish people are very much allowed to do that.
Well, we're pro-production.
Pro-production. But not everyone. I would say, like, there's always going to be a stripe that you're going to find that's going to say no to everything, you know, and that's okay. If that's your stripe, no judgment.
Right.
I would say, like, in other religions, and again, I am not speaking for other religions, but I know, like, for people who are Catholic, right, they believe life starts at conception. So the concept of creating a lot of embryos is problematic.
Ooh, interesting. Okay, that makes sense.
So that might be a problem for other religions. And I would say, like, it's complicated, right? Like, everyone feels differently. Speak to your local clergy member, make sure you're getting that counsel. But you know, as someone who's Jewish, I think it's really important to put out to other people who might be listening that are Jewish that there is a space for IVF. You know, if you're thinking, oh, like, my clergy member would never let me do that, I would say have the conversation, have that discussion, because there's a lot of room for that.
Interesting. To what degree can we, like, create designer babies?
This is like what everyone thinks genetic counselor does. Like, we make these beautiful, perfect babies. First of all, everyone makes beautiful, perfect babies. I love all babies.
That's true.
I would say we're, like, definitely not there yet. Like, we're not at gene selection. We are able to do certain things, which I think are really cool with IVF. And again, morally, like, people can have issues with this, but we're able to screen out, like, for embryos, we take a look at their chromosomes. It's called PGTA, or pre-implantation genetic testing with aneuploidy. So looking for chromosome numbers that are not typical. Which means typically you should have 46 chromosomes. The cause of most people having losses in their first trimester are because of a chromosome issue. Too many, too little, missing big chunks or extra big chunks. And so this is a really helpful way, again, to get people to their end goal faster.
So you would just maybe not use those, like, you would discard them?
You would discard the ones that wouldn't be genetically typical and put in the ones with the highest chance of a pregnancy.
Can people choose a boy or girl, or is that fake news?
So people can 100% choose a boy or girl because, again, we look at the chromosomes.
Oh, like, meaning you could just choose which one you wanted to implant. You can't decide. You can't change the...
Nope. You get what you get.
And you don't get upset.
And you don't get... Oh, some people get upset. But what's interesting, because I've counseled patients from a lot of different places, like I know in South Korea, they're not allowed to know the gender of the baby.
Wait, ever?
Nope.
Like, till it's born?
Till it's born? No, not till, meaning with IVF.
Oh, got it.
You cannot come in and say, I want to have a girl or I want to have a boy.
Okay.
It's completely not allowed. So different countries have different conversations.
Okay.
It can be an exception if there's a genetic issue. So for example, there's some genetic issues that are like X-linked conditions. And so mom will only want to have, let's say, girls because the chances of passing that on to a girl would be a lot less than for a boy, right? So she'll choose female embryos. And that might be an exception. But the United States, some people will come specifically to the United States because they want to have boys or girls, which is really interesting. So not everyone agrees with us on that one, but and again, there's reasons for that. It's controversial in some places, but you can choose to have a boy or a girl. And I always say, if you get to go through IVF and you do all that time, you should at least get to control one thing, right? We have so many things that are out of control. This should be your thing that you get to control.
Yeah. Wow. That's interesting. People come here to choose that. Okay, so we covered how we know who's fertile or infertile. I love a little blame game. I know that's really immature, but I really do. Gender selection. Okay. So to no degree can we alter a baby that isn't born yet, like outside of discarding, like, non-viable. We can't, like, alter things yet.
We're not there yet. There's a technology called CRISPR.
That's what I was going to ask you about, CRISPR.
Everyone's very excited about CRISPR. And CRISPR is really cool.
Okay.
But what people don't understand is, like, in this country specifically, you are not allowed to, like, use CRISPR on embryos or babies.
What is CRISPR?
CRISPR, I always think of it like genetic scissors.
Okay.
So you can cut out certain things and sometimes replace with other things. So in my world, right, if a baby was born with a genetic change that would cause disease, imagine if I could take my scissors, cut that gene out or instruction out and put in a working copy so the baby was healthy. That would be amazing. There are things like gene therapies that are kind of similar to that. We're not using CRISPR. right
So
now.
what does that mean? Like genetic experts or not, genetic counselors or not? Is anybody?
So there was a case, and again, I don't know so much about it, so I'm not going to talk in detail. In China, they used something like this. Apparently, they did the first genetically altered embryo, and it was really controversial around the world. That technology shouldn't be used on humans. There's a big belief in that,
Right.
because it's ethically a little gray,
Right.
right?
Of course.
But apparently, baby was healthy. So, that is all I know. But I know in the United States, we are not using things like that at all on our embryos.
And what about AI?
AI is going to start making its way into the fertility field.
I gotta imagine it's, especially if you're talking about so much of what you're doing is like collecting data from each person's history, plugging that in an AI system.
Is helpful. And again, I'm curious how it goes. I haven't seen it come up yet, but it doesn't mean it's not going to come up.
Right.
I'm sure it will. I know I'm sure they're going to be using that to screen embryos because, again, if you're a fertility doctor, you want good stats. You want to show that you make a lot of people have babies. And so if we can use AI to help screen for the best embryo, even though we have all the other data points, it's really cool. There are very interesting technologies that are coming out in our world. So we talked about PGTA. PGTM would be something where you would screen the embryos for a specific
And what's
genetic.
PGTM?
M is going to be pre-implantation genetic testing for monogenic diseases.
Oh.
So thinking about we would, again, if mom and dad, when you were carriers for something, let's say like cystic fibrosis or...
My niece has cystic fibrosis.
Which is a very common condition.
Yeah.
In certain communities, if we could screen the embryo before, we'd only put in the one with 1 or 2 working copies.
Right.
Making sure you would not have another pregnancy with cystic fibrosis. Hugely important. We can do that with PGTM.
Wow.
But again, we're not changing anything. We're just looking at what's there and making sure that we're making an educated choice about which embryos to put in.
Yeah.
There's another genetic test that is called PGTP, I believe. Again, do not quote me on it. I haven't used it myself, but it's essentially using huge scores of polygenic risk scores, which are really interesting. It looks at a lot of different genetic markers to kind of give you not a specific, but a generalized view of risk for certain conditions. And so some people have actually started using PGTP as well to what's going to be the healthiest child.
Right. But wouldn't
it's complicated because the data's not there yet.
Right.
So it's definitely interesting. I'm sure we're going to hear so much more about PGTP in the coming 10 years because people are already using it in this country.
Yeah.
It's not standardized, but people are using it. I've definitely heard about it. I haven't counseled someone on that yet, so I haven't encountered it myself. But it's really again, I always put people who are this is so ethically problematic. I'm
right. Oh, why? Because you were controlling whether a baby is sick or not, or how
so
like
for
playing
me,
God?
Yeah. So people really feel uncomfortable with that, and I understand that. But I'm also going to put people in this perspective of people who go through IVF have gone through so much physically, emotionally, financially. They want to have the best chance of just getting pregnant. And if this is something that they can do, remember everything, so much of their control has been taken away from them. If this is something they can do to take back some of that control, they're going to want to do that.
Yeah.
And they may not be thinking from your place of you had 7 kids because you just held hands with your partner, right? Or had a fun Thursday night. They may not be thinking like that. So I always say to people, put yourself in the shoes of someone that's coming there. Listen, genetics is always a very gray area that we live in.
Of course. The whole thing is gray.
Very gray. And we talk about we know people in our community who are disabled and they are amazing members of our community and we're so lucky and valuable to have them. But some people will feel well, in genetics, aren't you just trying to get rid of people with disabilities, right? Isn't that what you do? And I'm no, but it's complicated, right?
Yeah.
And we have a line that sometimes we don't want to cross. So I give credence to that, but I'm also that's why it's really important to have professionals doing this to make sure that ethical lines aren't crossed, to have professional organizations that are assessing are we crossing the line with certain things. And yeah.
Let's talk about eggs and embryos for a moment.
Sure.
I found out on from a friend of mine who was doing IVF at a later stage. She's one of the biggest misnomers is that they don't tell you is everyone's freeze your eggs, freeze your eggs, freeze your eggs, freeze your eggs. Every woman's being told if they're in an older, if they're getting up there, that they need to freeze their eggs. But what they don't tell women is you need embryos.
100%.
I learned that at 39.
And
This goes back to the education component. Like, I didn't know. I was like, oh, shit, you need embryos? I thought women just freeze their eggs and, like, later on decide to have a baby. Can you talk about that a little bit?
Let's do bio lesson first.
Like, please.
Like, 30-second bio lesson. You have egg, you have sperm. Those are both half pieces of the puzzle. You put those two together, that makes embryo.
Okay.
Embryo will eventually, hopefully, grow into, through lots of different stages and through growth, turn into a baby and then like a full-born, human being.
Okay.
But I want everyone to think about embryos as really early stage, like fetuses, like really, really early stage, like little cute little bouncy balls of cells. That's what they really look like. When you are freezing your eggs, you are only freezing one part of the puzzle, right? You're freezing half of the puzzle. And I feel very conflicted about this because on the one hand, it is such a great technology that has enabled so many women to really pursue their dreams without having that biological tick-tock. But the reality is eggs don't equal babies. They really don't. Embryos don't equal babies either. And I've talked about that a little bit, but the reality is it's a numbers game. Only a certain amount of the eggs that you're going to freeze are going to unfreeze, right? We lose things sometimes when we thaw them.
Right.
And only out of those ones that unfreeze, only some of them are going to fertilize with sperm to make an embryo. So we lose some more. And then of those ones that fertilize, only some of them are going to be able to grow, right? Some of them just won't. Like the growth will arrest, the growth will stop. Okay, now we only have some of them. And then we test them and we find out only some of those embryos were genetically normal. And so when you started off with 20 eggs, right, and you were so excited, you're like 20 eggs equals 20 babies, you may end up with only 2 genetically normal embryos, and you may put those in and not get pregnant.
Do you compromise egg quality when you freeze it and thaw it?
You don't compromise the quality per se, but like eggs are tiny and our embryos are a little bigger.
Oh, okay.
And so like I had a really great reproductive endocrinologist say this to me and I thought it was a great, like embryos are hardier.
Yeah.
So the chances of them like sustaining damage with a thaw are less than an egg, which is much smaller. So, it's not that you're compromising quality. It's just like literally survival, right? We're doing this amazing thing with freezing, but that even when you thaw embryos, sometimes you can lose them. Sometimes they don't survive the thaw.
Right.
But when people freeze their eggs and they think it's a one and done, a lot of the times it takes like 2, 3, 4 cycles to get the number. And I think huge important thing when someone's going through that egg freezing process is really sitting down. And this is hard because some people aren't in this space when they're doing egg freezing and thinking about how many kids do I want? Like down the line, I'm not having kids now. I picture myself with 2 kids. Tell that to your reproductive endocrinologist. And then say, how many cycles do I realistically need to do to get to those 2 kid stages? Like how many? Do I do 2? Do I do 3? And that will help you decide if this is for you.
And how long, you need is time.
100% time is better. Like I am a big believer in earlier is better.
Well, I have a question about that.
Sure.
Is there an optimal age for women, like who, let's say women, like they're like, I'm not where I want to be, or I want to pursue a career, or I don't have my partner. Is there a specific age that's best for women to freeze those eggs?
So again, remember we had talked about like every woman is specific. Go get your fertility evaluation. Some people, even though they're 22, their eggs might be like 44. Make sure that you are where you're supposed to be. But let's say you're typical for your age bracket, right? Listen, I'm a big believer in earlier is better. That's who I am.
Okay.
I would say like, try and do this in your early 30s. Okay. Like, do not wait, especially if you want multiple children. Right? Like, earlier is better. Your friends might think you're insane. I'm 28 and I'm freezing my eggs. That's crazy. Everyone does it 35. But your results might be so much better. You might have to do less retrievals. Right? Less money, less time, less effort. So, earlier is better. And I want to like hold space for like, for some people, it's like really emotionally hard.
Of course.
To like come to that place of like, I have to freeze eggs, even though like, I don't want to be doing this. Like, I want to have a partner. I want to know, but like, I just haven't found that person. It's so hard to find your person.
It really is.
Sending love to all those people. Like, it's hard. Take that time, but also like, for me, I'm like, get the evaluation earlier. And so, if you're working, you have 5 years to freeze your eggs or you have 6 months. Like, get the evaluation as early as you can, learn about that, and also understand that like as we get older, our numbers change. So like people will, say to me, again, I'm not a fertility doctor, but I'm somebody who's gone through this. I don't understand. My numbers were amazing when I did this at 29 and I'm 34 and like
Yeah.
my numbers suck. And I'm like, because your body changes, right? Like, I don't know if I can say weight loss, but like I'm saying, like losing my post baby weight after I had my first child was heck of a lot easier than when I had my second. My body changed. That's normal. Our bodies change.
Right.
So have that conversation, ask that question, and like just know. And again, I hate to be the bearer of bad news with IVF, but like it's not a slam dunk. It's a good chance and it's a good shot, but I think we've so conditioned ourselves to believing that it is the be all and end all, and it's not. It's a really great option, but option doesn't mean solution.
Right. You must have to tell people. Do you have to tell people like it's not going to happen for you?
That's not my job. That's usually like a reproductive endocrinologist, and I don't think they say that. I just think
Yeah.
like it's about being realistic. I have to tell people other horrible things sometimes. I have to tell them that the baby that they really wanted is sick,
Yeah.
and no amount of like intervention is going to help. I have to say that, and that's uncomfortable. I have to also say to people that like the way they thought they were going to get pregnant is not the way they get to get pregnant, right? If they want to lower that risk for genetic issues, I have to tell people a lot of things. Something that I think is really hard and we haven't talked about is really the interplay between cancer risk, and fertility, and how those worlds collide a lot of the time. So some people will have pretty extensive family histories of cancer, and they'll want to test their genetics. You can look at certain genes that we know are associated with higher risk for cancer. Big one that gets a lot of airtime is BRCA1,
Yeah.
BRCA2.
Brock, yeah.
Now, when people come to me, they've had that testing done and it comes back positive for a mutation or a genetic change. That might mean for a woman, when she's had that genetic change, that she is at higher risk for ovarian cancer. We know our ovaries are where our eggs are made, and that's going to be something where she may need to wrap up having babies a little sooner than her other friends or her other counterparts. That can be a really hard conversation. But I'm all about options, and I think it's so important that we get that information. If you learn anything else from this podcast, is really get your options so you can find out what works best for you.
So it seems like just from what we've heard today, like a genetic counselor and a like reproductive endocrinologist. Those are like your two kind of like warrior partners in this process.
Correct.
Where does the OB-GYN fall in this?
They're your 2.0. So sometimes they're going to be the people that are going to lead you to us,
Okay.
hopefully.
Okay.
They're the people that you get to graduate to. So when somebody does eventually get pregnant, they stay with their fertility doctor for several weeks, right? And then they graduate onto their OBs, and then they take over.
Okay.
But I think that's something that people will kind of get confused, like, oh, but she's a gynecologist.
That's
and
what I thought. I'm like, I thought that's phase one, but I guess you're right. You don't need them until you're with child.
Correct. But sometimes they're like the pathway that gets you there. Like some people want, a lot of the times fertility is just not covered in this country and it's expensive. So some people will try and do as much as they can through insurance, and I totally respect that with their OBGYN.
Yeah.
And then when they realize they may need to go to a reproductive endocrinologist, head there.
Yeah.
As like their 2.0. So it really depends on the person's journey.
Do you work very closely with the endocrinologist? Like, are you guys a little bit of a team, or do you do very separate work? And
again, it depends on the reproductive endocrinologist, but we typically do work together.
That's what I would think.
As a part of a team. Again, we do very, very different things. I'm there, on the genetic side, and that's my lane, and I stay in my lane. I am not getting you pregnant. I'm just trying to help reduce risk.
Okay.
OBs, they're getting you, hopefully managing your pregnancies. REIs, or reproductive endocrinologists, are really, helping you get pregnant. That's their lane. We also work with MFM, so high risk doctors.
What's an MFM?
Maternal fetal medicine
Oh,
specialist.
okay.
So for people who have a high risk pregnancy, we work with them as well. We don't typically work just with OBs because we're kind of like specialists in that way. So yeah.
And are you now in the nonprofit space?
I am in the nonprofit space.
So all this opportunity to make all this money and all this expertise, and you go nonprofit.
I'll tell you, I really felt, and like we mentioned this before, I got into genetic counseling after going through my fertility journey because I was like, oh, this is what I want to do. I want to help women and men and anyone who want to have a baby. And so that was like why I went into genetic counseling. And I did clinical genetic counseling in the reproductive space. And I loved it, a little peds at one point for pediatrics, which I loved as well. But I loved what I did, but I felt like we talked about education. Like it's who I am and it's in my blood. I was like missing that piece. And I had an opportunity to really work for a nonprofit, which is called Jscreen, to help bring education to regular people and to community leaders and to doctors and to different organizations to help them understand what genetic testing is, why it's important, how to access it. And I was like, this is it. This is my 2 point. I miss working with patients. I do. But for me, this fills up so much of my cup of like giving back to the community, making sure that like the wild, like access to care disparities that we have in this country are not going to be fixed by me, but I'm making it a little better.
Yeah, you are.
And, we, through our company, really allow people to get cancer genetic testing and reproductive genetic testing without having to jump through the hoops of finding a doctor to do it. We have ordering providers that'll do it. You can order it at jscreen.org.
Is it free?
It's not free, but we bill insurance.
Right.
So a lot of people will have it typically covered through insurance. Again, everyone's insurance is different, check, but
Is it just in California?
it's national, all 50 states. We've done all 50 states, Hawaii, Alaska included.
Wow.
So if you want that testing, you don't have to jump through, getting your provider who may or may not know how to order it and may or may not want to do it for you. You go onto the website, and the biggest part, Adele, that makes me so happy about it is not just testing, it's testing with a genetic counselor that explains your results to you.
Wow. That is huge.
That is huge, and then tells you how to use them and will coordinate with your doctors to make sure that that is actually being implemented. So shout out to Jscreen. It's an incredible organization. If you're interested, head on over. Cancer testing and reproductive carrier screening as well.
And is that just Jscreen, the letter J, screen.com?
Jscreen, SCREEN, .org.
Okay.
And you can, I can give it to you for the show notes as
Yeah,
well.
I will do.
But it's an incredible nonprofit. And, like I said, I miss working directly in patient care, clinical care, but I'm part of the outreach and education team. And I love what I do. So maybe I'll go back to patients at some point. But at this point, I'm just so happy to be part of the solution.
It's incredible. I actually didn't realize when we started this that you were such a righteous woman, but now I feel even better. But it's incredible work you're doing. Incredible work. I love the education component. It's so necessary. The access for people, you are making a difference. Bringing this information to people makes a difference, and even just doing conversations like this makes a difference. So thank you so much for your time today, and thank you for your expertise. I learned so much. So I hope people benefit from this, but I really, really appreciate this conversation.
Thank you, and thank you for having me on here. And like a big part of why I want to talk to people like you is because I want people who may not ever meet someone like me to have access to this information. That's how we can empower ourselves, take care of ourselves, making sure that we're living, I hate saying this, but like living our best life.
Yes.
Living our best life and really living a really empowered, healthy life.
Love it. Thank you.
Thank you.